Good evening, everyone, and thank you so much for joining us. We are just sitting quietly because we're waiting for people to come into the room, and the numbers are going up. So we'll just hold for a few minutes. So don't worry if you're not hearing anything at this moment. Okay, the numbers have slowed down. I know that we're expecting a lot more people to attend, but Rageshri, we don't have long, and I think we've a lot to talk about. So I think we'll get started. So first of all, I just want to welcome you. Thank you so much for giving us your time. And I'll come over to you in 1 second so that you can introduce yourself. But just some housekeeping notes for everyone. Once again, thank you so much. It's a dark Thursday, a dark, miserable Thursday night. So I hope everyone is sitting cozily. Obviously, we are going to record the webinar and it will be uploaded to our website so that people can watch it again. We find that, and we've already had requests in from people who can't attend tonight, that they would like to see it in there. Please do use, you'll see down at the bottom, you've got a chat box. It'd be really nice for me and Rageshri to find out who's in the room with us, because it's really hard sometimes when you're just talking into a screen. So say hello in the chat box. But if you don't mind, if you could then move over into the Q&A, so that we can keep an eye on questions, because we really want to make this as interactive as possible. So put your questions in the Q&A so that I can definitely keep an eye on them, because it's going to be me and Rageshri trying to watch the Q&A and have conversations as well. The closed caption function has been enabled for everyone. And yeah, let's get started. So if we can just close down the PowerPoint, because this is not meant to be, a PowerPoint presentation. So thank you so much for joining us, Rageshri. And it's a few months ago since we first had our first conversation, and you let me see a copy of your book, which I've really enjoyed. And the Patient Association exists so that we can make sure that the patient voice is heard. And we do that, and we really believe in patient partnership both in the design and delivery of services, but also in our individual interactions with healthcare professionals. And your book came through my door and I was like, this is the thing we have been talking about. So I want to hand over to you, and let's tell us a bit about you and the motivation around why you wrote the book.
Thanks so much, Rachel. It's really exciting to be here. So thank you for the invite. So yes, I'm Rageshri. I am a sexual health and HIV consultant based in East London and researcher, and I'm a writer. And I wrote Unheard, the Medical Practice of Silencing, which was published last year. And I wrote it for 3 reasons, which I won't take ages going into, but I think it's important to say why. So one of the main reasons was an experience I had as a patient about 10 years ago now. So I have endometriosis, which is a very common menstrual condition. And due to that, I was having difficulties getting pregnant and having IVF treatment. And after having my eggs collected on my 3rd IVF cycle, I had really severe abdominal pain. And I was really worried that I had a complication of IVF called ovarian torsion, which is when the ovary gets so large from all the hormonal stimulation that it can twist on its stalk, which is a surgical emergency. So, I was in a lot of pain. My husband saw that I was really unwell, took me to hospital. I went to A&E and I got given really good pain relief, and I was admitted for further investigations. And, thankfully the scan showed that I didn't have ovarian torsion. I didn't need surgery. And the medical team thought that all the hormones from the IVF had just really stimulated my endometriosis, which is why I was in so much pain. And I was in for several days. And I think because I didn't have that more serious diagnosis needing surgery, I was treated as a bit of a nuisance on the ward, and I did need to be there because I was in excruciating pain, but I was treated as if I was an attention seeker. Every time I asked for pain relief, my needs were dismissed. I felt the ward staff were rolling their eyes at me. And it was only because my husband really advocated for me to get pain relief that I got what I needed and I was able to go home. And I was really conscious of not complaining at the time or complaining when I got home because I didn't want to feel like I was more of a nuisance. And I got thinking about, why didn't I complain? Why did I feel like I'd been silenced? This was a healthcare team that was meant to be looking after me. They were responsible for my care, but I didn't feel like I could speak up and be listened to. And I thought if it could happen to me at that point, I was a new consultant. So, a senior doctor in the NHS, I can speak English. I know exactly how the healthcare system works in this country. If it could happen to me, what happens to everyone else? So then I started to feel quite guilty about it. And, it took me a few years before I could really talk about it. But I thought, I felt guilty because of the people after me who might go through the same experience. And that really led me on to writing this book. So that's the main reason. But a couple of other things were, I worked with some very marginalized patient groups living with HIV, highly stigmatized condition, often from very marginalized backgrounds. And I was really conscious that when we look at kind of healthcare policy, what gets funded, their needs weren't really being addressed. And I really felt, that they are speaking up, they're trying to be heard, but no one in positions of power really listening to them. So, these are communities that should be heard and aren't. And finally, I'm a doctor, I've been a doctor now for 20 years, and I'm aware that I don't always listen to the best of my ability. And, I'm sure I have silenced patients. And I really wanted to understand why that happens despite my best intentions. So it was kind of an exploratory, what makes it so hard for us to listen and to believe patients. So yeah, it all culminated in this book. And I was really pleased to work with you because I've mentioned the Patients Association in the book as a really good example of a patient organisation. So it's great to be here.
Oh no, I'm delighted to have you here, and I've learned so much just reading your book and looking at it, because I think the bit that comes out strongly to me, and as you talk about it, like there was one thing there that it took you a number of years to write that book. Was there a reason why it took you so long to write it? Was there something that, as a consultant, as a healthcare professional?
I think I felt quite ashamed that I wasn't able to speak up for myself or feel heard. And that shame really stuck with me. And I didn't really talk about it to many people for a long time. And then I just started to talk a little bit. And I wrote a piece for the Lancet, an essay which got a bit of attention. And I thought, okay, this is something that we need to look at. Um, I think it took me a while to really understand why it happened and to come up with kind of some frameworks as to why it may have happened to me and how it happens to other people. So I think a lot of it was about the research. And I think sometimes when you're writing about things that are traumatic, it has to be the right time. Like you have to
Yeah.
feel able to have it out there. And 10 years for me feels like long enough time to have something so personal out there. And I wouldn't recommend writing about something that's fresh.
No, no, that's fair enough. And it is very personal to you. And I think so in terms of, you talk a lot in the book about healthcare professionals, and you've just spoken there around inequalities. In your thinking, why do you think it happens from a healthcare professional point of view?
I think there's lots and lots of reasons. So first of all, I think it starts off in our training. I think we're not really taught the value of listening. I think, we are taught quite in a formulaic fashion of how to take a history. And then from then, what examinations we need to do, what tests to come up with a diagnosis and hopefully successfully treat a patient. But I think sometimes when we're taught how to take a history, we've become very focused and only focus on the bits that we think are important. And we kind of filter out the bits that we don't think are important, but actually may be very important to our patients. And I think we often think in the NHS about productivity and what is productive. So, and often that is, the amount of patients we see, the amount of tests we do, treatments we make, and people we cure. But I don't think we recognize that listening in itself is a therapeutic intervention, and just bearing witness to someone's suffering can in itself make someone feel better. And I think people go into healthcare wanting to help people, wanting to fix people, and very often, not very often, but sometimes we can't fix people. Sometimes people have got chronic conditions which we can't help, or conditions that that aren't to do with healthcare. And sometimes just letting someone talk and listening to them can make them feel better. And I think that in itself is a very important therapeutic tool. Um, Other things,
Yeah.
yeah, go
I
on.
just want to come back to you on the training.
Yeah.
I think absolutely, like when we talk about shared decision making, and and we've worked with healthcare professionals around shared decision making, and we've seen really good examples of shared decision making happening, but we've also seen examples where it doesn't happen. And we did a study with some healthcare professionals around shared decision making 2-3 years ago, and training really came out that you could see the link where people were very passionate, and not just doctors, because it's across the healthcare professional, but you could see where training had happened, in really good training around the role of shared decision making, the role of partnershiping with patients, and how it worked in practice then. And of course, what kind of things would you suggest that should go into? Because I think sometimes communication is seen as, people talk about like the soft skill, and you're like, it's a core part of who you are as a healthcare professional.
Yeah, and it's a core part of patient safety, isn't it? When we look at
Yeah.
reports into things that have gone wrong, it's often around communication and people not feeling heard or believed. So I think it is key. Um, in terms of communication skills, I think one of the major things is about recognizing power hierarchies in medicine. I think, we're kind of taught as medical students that at the top of the hierarchy are doctors, because, we do all this training, we pass lots of exams, we then do clinical practice. So, we have lots of medical expertise, and we're at the top of the tree. And then there's the allied health professionals like nurses, and other health professionals. And often at the bottom of that hierarchy are patients. And I think what we really need to learn is that other people's expertise is just as valuable as our medical expertise, which is, learnt. The expertise of our allied health professionals may be slightly different to ours, but it's just as valid and just as important for patient care. And patient expertise in their own bodies, their lived experience, and also their learnt experience, they may know more about their condition than their doctors, is just as valuable. And really changing that balance so that everyone's expertise is equally valued, I think would be a really important part of communication training, as well as obviously, those more kind of, how do you listen? How do you make patients feel like they're heard? So that kind of, valuing expertise and really believing our patients, going away from that kind of skeptical kind of, patients may not always be trustworthy. We have to kind of almost catch them out, which I think is also ingrained in training. I mean, we see it in the language of medicine, where we talk about patient denied this, patient claimed this. So, I think it's there ingrained in medicine, that kind of skepticism. And instead, if we just able to trust our patients more and believe, that they have their own expertise, then I think we'd be much better at listening and communicating.
So this is going to bring me on to the words that I find difficult to pronounce at times. So forgive me, everybody on the call. So we became very interested in epistemic injustice a good few months ago now, and we've done some webinars on it as well. And it was looking at the calls that the helpline, so our free phone helpline, take thousands of calls every year, and listening to patients in focus group telling us that their stories were often disregarded as stories. And I remember when I joined, I was like, oh, I don't like the word case study because it's quite impersonal. So let's talk about patient stories. And then I started reading this, and I was like, okay, well, this is dreadful, because that is helping this disregarding of stories. So could you explain a bit more to us around, so then there's hermeneutical injustice, and then there's testimonial injustice, which again you have covered. Could you explain those a little bit more to us?
Yeah, so epistemic injustice was coined by British philosopher Miranda Fricker back in 2007, and it's essentially an injustice related to knowledge. So epistemic just means knowledge, and she came up with two types. First of all, it's important to say that it's an important part of what makes us human is that ability to create knowledge and to pass it on to others. So to be able to speak and then feel that we have been listened to and heard. I think it's part of what makes us human. It gives us dignity. So it's a really important fundamental human thing to be able to do that. So if we can't do that, we experience epistemic injustice. So one of the types she talks about is testimonial injustice, which I think we see a lot of in healthcare. And that happens when someone is speaking and then due to prejudice about their social identity, they are less likely to be believed or listened to. So they're deemed to be not credible. So when I talk about social identity, it can be prejudice about their gender, their sexual orientation, their ethnicity, their age, their religion, their social class, their ability. So if I was to talk about my experience, I think I experienced testimonial injustice as a woman of colour. Probably seem to be slightly less credible when I speak, so less likely to be believed and taken seriously by healthcare professionals. And another, I think, good example of that is with sickle cell disease, where sadly we see lots of people say, you know, they're denied pain relief because one, people think they're lying, they're thought to be drug addicts and to be, you know, making up their symptoms essentially to get strong medication, and their serious illness is not recognised. And we know from all the reports, such as there's a big report out called No One's Listening, aptly, it's often linked to racism. So the fact that they are often black means that due to prejudice about them being black, around racism about due to racism, they're less likely to be believed and seen as being credible. The other thing about testimonial injustice is there can actually be prejudice because people are patients. So that's a type that's been found where there are stereotypes about being a patient with a chronic long-term illness. So patients may be deemed not to be objective about their own condition and may be untrustworthy because of that. So people can also suffer testimonial injustice just because they're patients, and that may then intersect with aspects of their identity. For example, if they're working class and had a long-term condition, they may be less likely to be believed by healthcare professionals. So that is one type, and I think that's probably the main type that we see in healthcare. And I'll briefly mention hermeneutical injustice, which is what happens when people are unable to communicate their knowledge to healthcare workers in a way that can be understood. So this may be because they're unwell, because their illness impacts their ability to speak or to think, or it may be that they communicate in a way that is not a kind of medical language that healthcare professionals are used to, so they can't be understood correctly. So perhaps they can't find the words, or the right words don't exist to communicate how they're feeling. So that inability to communicate then means that they too experience an injustice because they can't pass their knowledge on to the people who really need to hear it. And I think both of them do occur in healthcare and do mean that people go, you know, unbelieved or not heard.
Yeah. It's interesting that you just brought up sickle cell, because we just had testimony from patients in a report that we launched just before Christmas, where we looked at social determinants of health around cancer and blood disorders, and we had that actual experience coming really strongly across. And we've worked with John. There is a webinar on our website that we did around that kind of discrimination and not listening. And the other bit, so I suppose, you know, you think about sometimes how we speak within the system, which is why, as a patients association, we're always kind of, my team laugh because I talk about looking out the window, but always finding new voices to talk to about their experiences, because I think so much of this is about power, isn't it? And you talked about power imbalance, and our theory of change talks about that. And we actually ended up creating a jargon busting dictionary, because, you know, we all can fall into that sometimes, that we're using language that isn't in that plain language, in that accessible language. How, in thinking of all those injustices, you know, how and there is some of this in your book, but, you know, I'm not going to tell everyone what's in your book because they need to buy a copy of it and read it, because I'm not going to do it justice. But, how do we build power with patients? You know, you know, you talked about what happened, and that you felt that there was a prejudice because you were a person of color, woman, female. We talked to lots and lots of patients who don't have the power that you and I would have. And how would you suggest that we could build that power in people?
So yes, I think, being a patient made me realize just how hard it is to speak up when you're at your most vulnerable. And very much my argument as a book is we can't rely on people at their most vulnerable to speak up for good care. We in healthcare have to listen, but certainly while we're waiting for things to change, being empowered as an individual patient is really important. But also, I've got, a whole chapter on the importance of patient activism. So collectivizing together as groups and using your voice together to really get changes in healthcare can't to happen. So I think there's two ways. I think, trying to be empowered as an individual if you can be, but I don't think that is a must, but it can really help. Um, and that could include, for example, being very prepared for your appointments, perhaps even learning the medical language about your condition, because sometimes that makes one, your doctor will be better able to understand you, but also it gives you credibility. If you look like you know about your condition and you read up about it, you may be, they may take you more seriously, sadly. So you're deemed to be more credible. I think also knowing, your rights as a patient, so knowing that you can ask for a second, third, fourth opinion, knowing how to complain. And also, I think, bringing someone with you who can, a friend or a relative who can advocate for you, I think is really helpful, because they can stick up for you, they can observe, they can ask the questions that perhaps you've forgotten. So I think that's important as individuals. But yeah, I think collectively, I think is the way to go. So patient organizations are so important. And in the book, my specialty is HIV. So it was natural for me to use the example of HIV activists over the decades as a really important example of patient activism, because they got together and they changed how patients are viewed. So patients started to be seen more as experts than they used to be. They changed how clinical trials are run, how healthcare services are run, and even changed some of the language we use in medicine. So they're a really
Yeah.
powerful example, aren't they, of,
They're a
patients getting together.
hugely, like they're a
Yeah.
hugely powerful example. And I can't think of the name of that movie that I watched a few months ago, which showed that journey. And, I'd love to see how that could be replicated, because like we talk about patient partnership in design and delivery of services, and we have patient partnership principles, and we do a lot. And but I think what I find sometimes the real struggle in that kind of patient activation, in how you get the system to trust it, um to not put too fine a word on it. And an example would be, quite often I will say to people, why don't you go and ask patients with a blank sheet of paper? Why do you have to have half designed it before you ask people what they need? Why do you think the system feels that it has to hold that control?
I think it goes back to that power hierarchy again, isn't it? And that
Yeah.
kind of not trusting patients seems to be quite ingrained in our profession, sadly. So maybe that fear that, something will come out, that, anything could come out. And it's silly to have that fear, because obviously we need to design services with patients in mind. It's for patients, it's not us. So we're
Yeah.
never going to design a good service unless we know what patients want. So I think, yeah, it does go back sadly to that innate skepticism and power imbalance.
And yeah, and we see it. I think it was before we came on this call. We talked about, sorry, it was when we were on this. You talked about patient safety and patient so coming out of especially all the maternity issues at the moment that have come across, and so much of them, and Lord Darcy's review into the NHS talked about the culture of listening to patients. How If you had a magic wand, how would you change that culture? What do you think we need to put in place for that culture to change?
So, as I said, starts from training, but also in the institutions that we have at the moment. So, I think, healthcare services aren't built in a way which really encourage listening. We often don't have the time that we need or the private space that we need to have those conversations. And it's very hard to listen properly if you are stressed, if you're burnt out, if you've got compassion fatigue. So, all those things, I think, do inhibit good listening. I think we need to include patients meaningfully in every aspect of kind of service development, in the education of healthcare professionals, also in research as well. So I think all those things would make a difference. But people always talk about feeling a bit hopeless when they feel, there's so much that our patients need and we can't do things to help them. So, for example, if they're suffering from social inequalities, for example, like poverty, for example, or something like that, which obviously we know do cause health inequalities, but actually listening is a simple thing that we can do, which can actually really help improve health equity. And I always think if we can get services and communication right for the most marginalized, we're going to get it right for everyone. So it's well worth doing.
Saying that, I'm hoping I agree totally with you on if we can start with, and I'm going to reflect on somebody who came to me who had, quite serious learning disabilities, and he had received a letter, and it was addressed to him, absolutely addressed to him, it wasn't written to him. It was written in complex language that even I looked at it and I thought, this is so tokenistic. That I say, as a practicing consultant now, how would you advise some of the healthcare staff that are on here about, that communication? So listening's absolutely crucial, and we need to do an awful lot more about that. And I want to come back to listening, but then that kind of follow-up communication, that genuine. So we talk about genuine two-way communication. Is there sometimes a fear from a healthcare professional that if they work too much with the patient that they might make a mistake, or sometimes patients might want to go down another route and they don't have the knowledge of that route?
Yeah, I think that is possible. And I think sometimes we kind of stay in our boxes because we're comfortable with that. And I think going outside of that, listening to something new is scary, isn't it? But I think it's really important for us to be uncomfortable. We can't be comfortable all the time, and nothing will change unless we listen to views and experiences that we haven't listened to before. So I think becoming comfortable with being uncomfortable is really important. And I think if you're a healthcare professional, have a look at your service, have a look at the population you serve. What kind of people do you see? Do they have special communication needs, for example? Do you work in an area where people are particularly from one ethnic community? Do you have, think about all the different communication needs, and then try and get some patient voice to understand what they would like, and not just tokenistically either. So not just one or two people, get a diversity of people if you can. If you think, oh, I've got this great room of people who are giving me feedback, but there's obvious groups that are missing, think about who's not in the room, who else's voices do you need? So yeah, find out from your patients what they need and how to do it. And one thing I talk about, really important though, if we are going to get patient involvement, which we must, is to make sure we're doing it properly and ethically. And I have a whole chapter on that in the book.
Yeah.
So we must make sure that we're recognizing that people are working for us by giving their opinion. This is epistemic work, it's knowledge work, and we should be remunerating people adequately where we can. We should be supporting people pastorally. So one of the wonderful things about this webinar is that, we're going to have a debrief afterwards, and that kind of thing is really important when you're asking patients to speak up, is providing that kind of support. I think it's wonderful. Also
It's
making
so important.
Yeah, it's so important. And also making sure, that when things are suggested to us, is making sure that change happens. So we're not just listening and then nothing changes. So, if we're asking patients to speak and be involved in that service development, really acting on their suggestions, otherwise it's a waste of time for them to come and help us. So those are the things that I would suggest.
So I agree totally. And we're actually doing a small piece of work at the moment. One of my colleagues is analysing, I think, 500 responses to a quick survey that we did around reward and recognition for patient involvement work, just to really build and see, what the motivations are, what happens out there, so that we can do. And but I think you talk about listening and and listening to what patients need, and then developing the service. But I suppose one thing that I say to a lot of people that I talk about is sometimes, I will give you feedback, you will give me feedback. We may not be able to do all the things that we have both fed back on this call, but feedback why you can't do it. So often we hear from patients, especially if they've raised a concern about something's happened in their care or something, and they go, we fed back and we got a letter back and it said, with respect to your complaint or your concern, and then they ignore one whole question because it's in the too difficult box. So rather than having that open, genuine conversation to say, it's a really good idea, we can't do it now, we'll look at doing it in 6 months' time. It's ignored. And I find that really insulting for patients. So much I want to ask you to go back to my list. So one of the things that we had a webinar a few weeks, well, it's a few months ago now, and it was with patients with multiple kind of long-term conditions, and they were different age groups, and they were all the age groups really, and a lot of them talked about feeling that because they had so many conditions that they felt like they were being left behind by the system because nobody was coordinating their care, nobody was supporting them in coming through. So that very basis of the admin not working and the communication not working before you even get to your appointment, they were being left behind in the system. How do you think the healthcare system can work around, to make sure that everything around the patient is so much more seamless?
That's such a big question. And I think because, there has been problems with funding in the NHS and, I think people are finding things are falling through the cracks. So as a patient, you're much more likely to have to, do the admin yourself. You have to chase things constantly. Even for me as a patient, I'm constantly chasing things because you're worried you're going to fall through otherwise. That's a really good question. And obviously, in an ideal world, we'd want more funding for the NHS. We want better IT systems that communicate with each other. All those things I think would work. But I think where we are at the moment, it can be, talking to your, so for example, one of the things I talk about, which can really help in terms of listening and patient safety, is continuity of care. So trying to see if you have a GP that you get along with, trying to see them every time. So I think, there's ways in which GP practices could perhaps allocate their appointments. So, it's always, more recently, it's been about seeing someone very quickly. But it would be any doctor, whereas giving patients more choice to see the doctor they want, even if it may not be within that week, it may be a few weeks away if it's something that's not urgent. So kind of making the appointment systems more accessible, making the IT systems easier to use, and also remembering that not everyone has digital access. So making sure that people can walk in and speak to the receptionist and be listened to and make an appointment, or they can phone in and not having phone systems where, you're waiting for hours. I think those things can help. And at the moment in the hospital trust where I work, we've introduced Patients Know Best, which is, as you know, is a computer system, which means that patients can now access their letters, their appointments, and see their blood results. And I have to say, like most appointments now, I show patients the website on my computer because it's just so handy. They can be in charge of, their information. So I think those are things that are happening now, which could help, whilst, obviously what we would like in the long term is more funding so the systems aren't, there's no danger of falling between the cracks then.
Yeah, no, and we speak to a lot of patients about accessing their medical records, and so I quite often struggle to access their medical records, and we know that the health service is really looking at how they can develop the NHS app, but and we've done some training because I think the thing is, like you say, there is digital inequity in the country, so we've got to look at how people can access their records. But where they can use the app, it was small things. Like we did some work with, we did reports, and it was like, we don't tell people that you don't have to have a smartphone to get the NHS app, that you can get it on your computer, or you can use it in a library, and if they still exist and have computer. But it's about giving patients power. So I think that's the other thing. There's something about training and development, and we've done work with community connectors to look at how they can then take the knowledge and work with communities locally. Because I wonder, sometimes is part of the problem, that we continually think about health inequalities and doing to people rather than becoming part of communities and understanding. How would you suggest that as a healthcare professional, our teams, that you said earlier on, and we were talking about the Royal London and that community around there before we came on the call. How do hospitals and trusts and communities get to become part of those communities? Because we can't keep trying to do things to people.
Absolutely. And I think, there's that often used term, hard to reach communities, and
Oh,
it's not that they're hard to reach. We are hard to reach as services. Often it's the other way around, isn't it? So we need to reach into those communities. So it may be, having open days to invite some community groups and actively reaching out to them and saying, what do these communities need from us as healthcare professionals? And it's about building trust. I think that's one of the main things. And, during COVID, there was a lot of discussion about mistrust of healthcare services. So particularly when it came to things like COVID vaccination. So, why were these communities not accepting it? And we have to understand it's due to a long history of bad things happening, reasonable reasons for people to mistrust healthcare services and other governmental services because bad things have happened in communities to them. So understanding that mistrust exists, and part of that is not listening as well. So if you feel you're not being listened to or believed, your relationship with the healthcare team is going to not be good. You're not going to trust them because you don't trust them with your information because they don't believe you or they're neglecting you. So all that mistrust with communities and on an individual level needs to be acknowledged. And instead of blaming the communities for not trusting us, we need to understand our role in that. So reaching out to those communities, not waiting for them to come to us, and starting those conversations and making them partners, as you say, is really, really important. It means that we can then, develop services that are useful for them.
Yeah, no. And then when we talk about some marginalized communities, I think, we talk about English as second language. I was doing some work yesterday with the Welsh Select Affairs Committee, and even first language Welsh speakers coming in across the border and not being able to. What's the role? Like, the role of translation and interpretation is so important, and that so shouldn't be the family member, as far as I'm concerned.
Absolutely right. And, coming from my sexual health background, we don't want to have anyone there to interpret because
Oh,
we don't
God.
know the dynamic between them, or, if there's a power dynamic between the person they know who's interpreting or not. So I think it's really important that we have translators in the NHS. And I think, people talk about cost, but I think it is money saving in the long term, because if people are not understood, they may come to harm because they might not get the right treatment they need, or they may present further down the line more unwell. So I don't think, I think it's money saving in the long term. And I think there's different ways of doing it. Like, I remember before COVID, it was often about getting an interpreter, a professional interpreter, to come in with your patient and sit with you. But now, we have things like, we have language lines, so we can use a telephone interpreter, which is often good enough. And, when that's not available, there are other things. So we've had an iPad in clinic, which again has a digital interpretation on it. So I think there's new technologies coming, and obviously Google Translate, etc. So there are ways in which, we can apply that in clinic. But I think having translators is so important. And you're right, we shouldn't be using family members. And it's a big responsibility on that family member.
Oh,
Often it's
completely.
children or, teenagers, and that's a lot of responsibility of them. It shouldn't happen.
And I think you make a very good point, because then there is I'm trying to reflect the questions I'm getting in themes here, but I think you make a very good point about the economic benefit. And I think, you look at your book, The Medical Practicing of Silencing. If we are not listening to patients or their family, depending on the age, and there's comment in there about how do we listen to children and young people. And that webinar I spoke about, there was a young person on there who said that her GP or her consultant, like, it was her healthcare professional, she was in university, and her condition meant that she couldn't really go to university and she couldn't socialize. And it was completely disregarded as not important. Well, it's not, at least you can't go to your work. And I remember being really upset for her on the webinar, because I was like, but that was the stage of your life. That's living a life. Do you think that as a system, we don't understand the economic benefit, that we can get it right better if we do the what matters to you and we really listen, and then we go on the right journey with together as partners, as a healthcare professional and a patient?
Absolutely, yeah. I mean, we want to be getting things right, and why wait down the line when we've realized what we've done is wrong and then we get the feedback? We should do it right from the start, shouldn't we? And I think in the book I talk about there's a case of a trust which employed a patient experience executive. Well, I can't remember the actual name of the
Yeah, I
role.
have that here somewhere. Yeah.
Yeah, and they get paid the same as everyone else on the executive committee of a hospital, as they should. But people were saying, why have this? This is this would be great to have, but we need to focus on the essentials, like the number of beds we have and the number of nursing staff. And that's just silly. We need to have patient involvement in every way, and we need to value it. So in that trust, they were valuing it by having someone who's in charge of patient involvement and patient experience. It's really important. So money saving in the long term.
Yeah, we did a really good piece of work with the London hospital a couple of years ago, and they were developing a new centre of excellence. So what they wanted to do was bring healthcare professionals and patients together to talk about what this could look like. So we facilitated that piece of work for them. And it was so moving because actually both healthcare professional and patients were like, sorry, did that oh, okay. Just, they didn't think about appointment times. We've done a lot of work with NHS to try and understand why people might miss their appointments, and we're trying to change that language, that
Yeah.
it's not a DNA, which again is blaming patients for not turning up, rather than being curious about why people can't. So I think that's quite interesting, getting people together, and they learned so much, and the feedback was so valuable, and it ended up with a really good unit set up that met the needs of the patient, allowed some patients to continue work, which they'd had to give up in the past because of times of blood tests and taking so much time off, but also gave patients a real insight to how healthcare professionals have to work as well within these systems. And then you end up having that place of mutual trust and confidence.
Absolutely. Understanding each other's roles and experiences is really important. And I think for healthcare professionals listening now, it is important that we get it right, because we're all going to be patients at some point in our lives. So we have a stake on a personal level for us of getting healthcare services right. The other thing I also say is that relationship is so important. And when, listening to patients, getting to know more about them, it just makes our jobs more fun. It's much more enjoyable.
Yeah, no, I think it is. I love getting to know people, which is why I love doing webinars like this, and chatting to people. Because I know in your book as well, I bored everyone at the beginning in my team because I kept talking about the quote from Martin Luther King. And I think we're 2 days out from Martin Luther King's day. And when he talked of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And that slightly blew my mind, because I was, that's 1966. We're 2025. Why is it still happening that we have voices that are not being heard because we're not trying to hear them?
Yeah, it's such a powerful quote, isn't it?
Yeah,
And it's
yeah.
because healthcare is meant to look after us. We're meant to feel safe in healthcare. And for so many people, they don't feel safe because they don't feel heard. And I think, yeah, I think a lot of it is around I think it's uncomfortable for us as healthcare professionals to feel that our patients aren't being heard by us. And I reflect on, complaints that I've had where patients haven't feel heard. And, my first response was defensiveness. Of course it was. Like, I felt like, I'm sure I listened well. Like, I really want to listen. But understanding that often it's not just us, it's the systems that the way we've been trained, the systems that we work in, it makes it hard for us to listen. So I think until we really change the systems issues, including education and the way our healthcare services are run around listening and communication, then things aren't going to change, sadly. And, Martin Luther King was also thinking a lot about people who face discrimination, so people from all marginalized communities, communities of color. Unfortunately, that discrimination still exists in many areas. And, there is bias in society. We all grow up in society. We all have our own forms of bias. And again, it's about recognizing that, being comfortable that we all have bias, and then really reflecting on when is it that my bias may come out. So, you know, I talk in the book about how healthcare professionals can listen better to their on an individual basis. So really reflecting on, when do you listen badly? So for me, I'll do a morning clinic, and by about 11 o'clock, I'm not listening well because I'm hungry. So I know I'll eat a banana, I'll walk to the loo, I'll come back, and I know I'll be better for the rest of the clinic. But also recognizing where I have bias, and my bias is I I don't think I listen as well, for example, to people who look like me who are older, the person I'm going to be. And I think that's a lot of bias around, stereotypes of South Asian older women, being very anxious, having symptoms which are deemed to be all in the head when actually obviously very real physical symptoms. And I have imbibed that kind of unconscious bias into myself, which I may face as I get older. So I think we all have biases, and it's just about recognizing what they are and when they come out.
I think the best piece of training I ever did was one that really got me to think about what my biases are, and recognizing that, you do have every single one of us have biases, and we need to think about those things, and we need to think when we're in. But I think what comes out from you, Rageshi, is of course you're not perfect. There's going to be times when you haven't listened. There's going to be times when I don't listen to my team, or I probably don't listen properly to my family. But how is you obviously, and you can see it in your book, you reflect on that and look, and I hope that I would too. So how can we build that reflection into the time that healthcare professionals have?
So I think we really need more debriefing and supervision. And, often for most teams, we only debrief when something terrible has happened. So there's been an unexpected death on the ward. The team may get together to debrief. But I don't feel like it's really built into most professions, apart from maybe psychology, where they have regular supervision. And I think having those regular supervisions or debriefing with colleagues means that we can reflect on uncomfortable consultations, where perhaps, you might be at the end and feel, I don't think anything bad was said. There was no conflict, but I feel like I haven't done what the patient wanted. Like it just felt wrong, and I'm not sure what happened. And talking to colleagues, debriefing, getting advice is all really helpful. And I think that's really needed. And the other thing to say is that listening can sometimes be very uncomfortable. So if we are bearing witness to someone's suffering, if there's not much we can actually do to help them apart from listen, that's a lot for us to take emotionally. And again, that debriefing is part of that. So letting us deal with those uncomfortable feelings that may be projected onto us and that we have to hold, but making sure we don't go home with them.
Absolutely. And I think that's a real key point, because obviously the patient association is all about patients. But we really reflect, and I have worked with healthcare staff for years, and really reflect the impact of doing a really good job of supporting and caring a patient at different stages in their lives. And without that safety net of conversation, of mentoring, we're not being fair to frontline staff, are we?
Yeah, I think it's, well, I have a whole chapter on how doctors don't get heard. So, I think that listening goes both ways, but also while recognizing who's got the power, and often it is medical professionals, not the patients, who have the power.
Yeah, no. So I was laughing at my team the other day because your book's now full of highlighter pens because they want to read it after me. So I think I might have to buy them the Kindle version, because they'll be like, oh, she's ruined the book because she's highlighted loads of stuff and she wants to talk. And then I had to calm down on the highlighter. Okay, I'm just going to quickly look at the questions because we're slightly and I have been looking at them, but I just want to make sure. There's a lot of questions in there that and some lovely examples which we will pull. So I'm just going to find this one. So there's somebody in here who's doing community building with the community of Asian women to foster conversations and share stories about topics where inequalities persist. And then a few other people talk about what advice would you give to people in setting up that activism that you talked about around HIV?
Yeah, so it's about trying to find other people with a similar condition to you. And what's really exciting now, which they didn't have them, was the online community. So finding online forums and perhaps connecting that way, or if that doesn't exist, maybe talking to your clinic about creating a patient group, which can meet, out of clinic to have those conversations. So that would be one way to start to meet other people, to share lived experiences and advice. And I think there's also something about looking at other patient activist organisations to see what they've done and what you can learn from them as well. So I think maybe, yeah, starting online is a good way to start because there's so many online communities now.
Brilliant. Yeah. No, I think we do have a resource on our website around kind of community developing, and we've been working with Bola, who's Director of Inequalities in NHS England. She's fabulous, but is doing so much work around how you become part of those communities, and sometimes that is the online part of the online community piece that's really, really important there. Um, So we've talked a lot about listening to patients, and we talked about the economic value of working with patients and saving it. And Darcy talks about listening to pay. It highlights the cost of not listening to patients, and stating. It actually states listening to patients about what's important to them would help the NHS deliver tangible improvements to people's experiences of the NHS. So we're talking about community activism in terms of patients. How do you use your role now, Rageshi, to get healthcare professionals to talk about this?
So there are quite a few healthcare professionals who are also activists.
Yeah, yeah.
Yeah, and I'm very lucky to work in a specialty where we've become activists because the patients have made us so. So we work very closely with patient activists and learned a lot from them. So yeah, I think, healthcare professionals can be really important advocates for patient groups as well. So trying to find one who is willing to advocate for you and join in, I think is really a good thing. And if you're a healthcare professional and you're really passionate about something to do with healthcare, see if there's groups that you can find, or maybe start one, or go to a patient organisation, say the condition that you're interested in, and just say, how can I be helpful? What would you benefit from? Would that be, a webinar about education about the condition, or can I help in terms of helping to what's the word I'm looking for? So if you're writing letters to MPs or whatever to try and get more attention on something, can I help with that? Can I co-sign? So I think there's lots of things that can be done. And I've had quite a few voluntary roles over the years where I've been on medical boards of patient organisations, and they've all been led by patients, but they needed us to help them when it comes with maybe creating campaigns or writing resources or doing education webinars. And it's been some of the most fun work that I've done outside of my day job. It's been great to be part of those organisations and feel useful.
Brilliant. Somebody's just brought up, and it's a real other good example of patient activation, and it's the Oliver McGowan training around learning disabilities. I'll send you a link on it, but that was his mother, and somebody's saying here it's not still being followed, but I think I saw her this morning on the webinar, and NHS England have taken it on, CQC has taken it on, and CQC are now kind of looking for it at inspection level. Now there's a lot more to be done. It's not perfect by any means, but it's another real example about how patient activism, family activism. You talk about Martha's Rule in your book, and what Merab and Paul managed to do to get Martha's Rule rolled out in pilot, and there, as a critical review when you think you need it as a loved one. So we do have some good examples, but we have lots to do, but we only have a few minutes left, so I don't think we're going to do it in the next few minutes. Rageshi, if you were to walk away and say, what are the three things you'd love? We've got a long-term health plan coming. We're putting in lots of evidence into it about where we hear about patients. So, we have a stat there where being listened to, believed, or taken seriously was important for a majority of our respondents, but only 38% felt that they had been. So, there's a long way to go. We know Darcy's saying it. We know that people, especially that it can cause a lot of mental health issues if people don't feel they're being listened to. So you can see people getting sick. So what would you like to see as a core message coming out of the long-term health plan?
So I think it is about properly valuing patients and their lived experience and learned experience as being hugely important and core to everything in that plan and any changes that are made. And part of that means investing in it as well, so that we have, a diversity of patient thought and leadership, and they are remunerated properly. So really taking it seriously. And I think, it's been years and years of safety reports saying that people haven't felt listened to, and that's another reason I think I wrote the book. It's just it was a persisting thing that kept coming up, and no, I didn't feel like anyone was really looking at it in enough detail to really understand why it was happening, and that was one of the reasons I wanted to do it. But yeah, I think that would be the main thing for me, is properly valuing patient voice and incorporating it, and making sure people are paid to do it, and there's a diversity of thought there as well.
We'll make sure that gets into our next submission. So everybody on the call, of course, there is the workshop in the box on the change.nhs.org UK, where if you're working with communities and you want to get voice into that NHS long-term plan review, submit it before the 14th of February. And I think one thing I just want to reflect is in your book, you talk so much about, LGBTQ, Black Caribbean, Asian, the whole range of areas that we see inequalities happening. The one area I think sometimes, and not that you do, but I think a lot of people sometimes forget about geographical and areas of high deprivation where we're seeing. So, I was at a talk the other night where people in areas of high deprivation, their life expectancy can be nearly 15 years less. And
Yes.
how do you think the system could do that kind of geographical bit differently? Because I think sometimes we see an inequality impact statement that looks rightly at all these areas, but doesn't pick up living in an area of high deprivation where you do not have the healthcare services that you need in your area.
So I think, I think that's been documented for ages, with the Marmot report showing
Yes.
that clear link between deprivation and life expectancy and, healthy life years. I think it's really been picked up recently. So you talked about Bola, who's the health inequalities lead. So she's been really concentrating, looking at coastal communities, for example, which are areas of high deprivation. And, I've learned a lot from listening to her about that. So really recognizing where those spots are and looking at the services there and thinking, again, how are we going to get into the communities? These areas might have higher need, and they may have patients who are less likely to feel like they can speak up. So we need to make an extra effort in these areas to make sure they get the services they deserve. But of course, and I do say in the book, we need a government that listens ultimately. And so much of health is outside of healthcare. It's about, social equality, reducing child poverty, reducing deprivation, and that needs to be tackled as well to improve health outcomes for people in deprived areas.
I think you're completely right. And one of our election manifestos was about health in the heart of every government department. And till we do that, I think we, and to be fair, this isn't all the NHS. This is about a government structure that we value. And I think there's somebody's just put a quote in and said, is it too simplistic that we just ask that we treat each other as we would want to be treated, to be listened to be respected, etc. And I think, that's a nice way to finish, because I think that's exactly what we need to do. Dr. Rageshri, thank you so much. Now, is there anything you want to say to us before we do finish?
No, I feel like we've covered everything. Thank you for a really great discussion. And my book is out there if anyone wants to read it. So please do go ahead.
Okay, we're probably not meant to be doing big marketing for your book, but it comes out in paperback very soon, doesn't it?
It does in July, yeah.
July.
Yeah.
I see. I've done my research. So, and I think it's out on Kindle, is it?
And audiobook and hardback.
Audiobook, that's it. Yeah,
Yeah.
yeah. So yeah, I totally recommend it because it is a really good read. And I think what it does is it gives you, I came away with loads of thinking about what I could do what we could be doing differently as a patients association. So that's why, and you know, that's a fabulous thing when you learn that. Well, I think we are just on the hour. We have lots of messages to come through. I'm glad that we're getting a lot of thanks through, that you've been very empowering and super interesting, and it has been super interesting. So thank you so much for giving up a Thursday night, because I know you're very busy. And thank you all for coming, because we couldn't do it without all your chats and your conversations. And brilliant. We will do our best to write this up. We're hoping that we can work out, we need to talk about how we might work out our first podcast, which is where we want to start going to. But this will definitely be up on the website and you'll get a link to it. So please do send it out to all your colleagues and friends and give us some ideas about other webinars that we could do. We'd be really interested. So on that, I'm just going to let you know about, which, you know, has come well. So at the end, in March, at the end of next week, sorry, we are launching an animation with British Sign Language on how to become more prepared as a patient, things to think about. This is something that we designed with patients, which is what we do everything on. And we have a guide as well, but we're going to have a webinar with the people who are on here and patients to talk about the guide and talk about how it works for them. So please do sign up. There's going to be a link somewhere very soon for that. Once again, thank you so much. Now we shall go for our debrief, Rageshri. So I'll see you on the other
Great.
side.
See you on the other side.